Well, welcome again. We're thinking about the Wuhan coronavirus, and it's the 4th of February today, so let's get an update. And as always on this site, we're going to try and be evidence-based, with a little bit of extrapolation thrown in sometimes, which are my opinions. Let's look at the figures for today to begin with. So, 4th of February 2020, novel coronavirus. Confirmed cases on the Johns Hopkins Oracle this morning, 20,679. Confirmed deaths, 427, but more recovered, 711 recovered. So that's good. What's not clear, though, is the criteria that are being used to define recovery. I would like to know, for example, if that means they're now clear of the virus. And of course, we won't know if they're going to suffer from any sequelae for some time after this. So we're not quite sure yet what that means. Now, I had a major malfunction yesterday. I got my months mixed up. Let's clarify it now. So the Lancet article I'm talking about was the 31st of January 2020. That's when it was published. And the estimated infections as of January the 25th, 2020. So the 31st of January article in the Lancet estimated the state of play on the 25th of January. I was talking about December for reasons best known to myself, which were wrong. I apologise, I've confused some people and some of you are quite upset. I understand justifiably I got it wrong. But this modelling, and we stress it is modelling, indicated that there were 75,000, nearly 76,000 people suffering or infected on the 25th of January. And given that the doubling time is 6.4 days, some people are actually saying less than this now. Actually, some people are saying nearer 5.5 for the doubling of the number of people the number of people infected. So if this figure's right, and we don't know, it's modelling, but it's based on good epidemiological methodology. If it's right, then 31st of January, there'll be over 150,000 cases. 6th of February, there's scheduled to be 300,000 cases. And you can make a figure up for what it is today, just as well as I can. So that's where we're at. But let's get down to the important business of the day now, because we've had an article published in... This has been published in New England Journal of Medicine, very reputable journal. First case in the United States. So part of the problem has been that detailed information about individual cases from China has been a little difficult to interpret, to understand. So what we have here is this is the patient, the first patient. So what we have along the bottom here, these are the dates in January. So they're the dates. Now this chap returned from Wuhan in China on the 15th of January. He came back from Wuhan in China. And then he started to feel unwell, but he reported for medical attention on the 4th. They didn't know what was wrong with him, sent him home, but then he came back in on the 5th. And he was in hospital. This green line is the time he was in hospital. Now, this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 days of his hospitalisation. These are the days of the illness here. So first day, second day, third day, fourth day. So he's hospitalised on the 5th day of his illness, day 5 of his illness. Now, I'm going to give you a brief version of this first of all, and then we'll go into more detail later on. So if you want to cut the video when I finish this important bit, you're welcome to. But let's notice first of all the features. So fever. So he had fever from day 2 all the way through to day 12 of the illness. So all that time he had fever for 10 days. It's quite a long time. Now, we don't know what his fever was there, but he said he felt like he was febrile, but the doctors and nurses only took it then. So it was febrile for 10 days. So fever is a big feature here. And even before the feature, he developed a cough, and it was a dry cough. So you can get dry coughs or you can get productive coughs. They can be dry or productive. And this was a dry cough. He wasn't producing a lot of sputum. Later on, I think he was producing more sputum, but initially it was a dry cough. And interesting, the article actually calls this rhinorrhea, which means a runny nose. So he had a runny nose, but not till near the end of the condition. The upper respiratory features, the coryzal, common cold features, weren't presenting early on. Interesting. He became very fatigued. So from day 2 of the illness through to day 12 of the illness, he was very tired. A lot of fatigue in that early part of the illness. Nauseated from day 4 to day 6, and again nauseated on day 10 of the illness. Vomiting from day 4 to 5 of the illness, and diarrhea from day 6 to 7 of the illness, and abdominal discomfort that went with the diarrhea. Now that's not surprising that the abdominal discomfort goes with the diarrhea. Often you get crampy pains before diarrhea as the fecal material is propelled along the colon by a process called mass transport into the rectum. So they're the main features for recognition. So early recognition of the disease, we're talking about dry cough, fever, generally feeling unwell, malaise, achiness, all that cold, shivery feeling that goes with a developing fever. They were the first features: cough, then fever, followed by undue fatigue, and then followed by nausea and vomiting on day 5. Now, it's important to stress this is only one case, so we can't extrapolate general principles from specific instances. That would be called inductive reasoning, and it's not a good way to reason. What we need is many more cases, but given this is all we've got at the moment, we have to go with it. So I'm going to raise a major concern now. This patient, it's only one patient, but this one patient developed pneumonia, infection in the lungs at the level of the alveoli. The doctors knew this because they did a chest x-ray and they could see the consolidated white fluffy areas in his lungs, characteristic of the alveoli being consolidated and filled with fluid, or some alveoli being consolidated and filled with fluid anyway. And the thing that's concerning is he developed this late. So it wasn't until day 9 of the illness that he became short of breath, dyspnea, because he had pneumonia. And also his oxygen saturations dropped. Now your oxygen saturations now are probably around 90, 97, 98. His dropped to 90. Not critically low. We normally like 94 to 98 in hospital care for people without chronic bronchitis. If they've got chronic bronchitis, we'd want 80, 88 to 92. But he was given oxygen here. So his oxygen saturations on room air were 90%, so he was given additional oxygen for these 3 days, which of course is exactly the right thing to do. Exactly the right thing to do. He was given this oxygen. And we don't know to what degree that maintained his oxygen saturations. We presume it helped quite a bit. Now, the other supportive treatment he gave, we're going to talk about in more detail later, probably on a second video, because I want to get an important point across here. And the point is, if we have hundreds or thousands of cases, we're not going to have the facility to give a few thousand people oxygen at the same time, or to treat people with pneumonia at the same time. So what we really need to know, I mean, the guesstimate at the moment is probably about 30% of patients develop significant dyspnea. And we're assuming that that dyspnea, that difficulty in breathing, is probably caused by pneumonia type features. And when your oxygen levels drop, you become hypoxic unless you're given oxygen, and caused by the pneumonia. So my main concern is that most healthcare facilities around the world certainly in healthcare facilities I'm familiar with, where I've been working for 40 years, we don't have enough oxygen to give more than a few hundred people at a time oxygen. And if a lot of people need oxygen all at the same time, we've got a serious problem. So I'm currently communicating with healthcare providers suggesting that increased oxygen is made available. I really hope we don't need it. If we don't need it, that's absolutely fine. But if we do, better to be prepared. Now, I think I'm going to leave that video at this point because I've got my important point across. And I'm not quite sure what YouTube is doing with these videos at the moment either. There's some problems. So we'll put that one up for now. And I'll do a second video that contains more detail about this patient's management and treatment. And the implications for management and treatment, and the implications for infectivity on the next video.